Okay, it's just after 12, so let's go ahead and get started. Can everybody see my screen okay?
Yep, looks good, Melissa.
Thank you. So hello, everyone. My name is Melissa DeMars, and I am the Upper Peninsula Behavioral Health Consultant for the Michigan Opioid Collaborative. Thanks so much for joining us this afternoon. This is our webinar on Kratom, aggression, and psychosis presented by our staff physicians, Dr. Jonathan Morrow and Dr. T. Michael Cates. Before we get started, I'm just going to go over a couple of things. You'll see on the screen here, we do have CME information if you're trying to obtain CME credits for today. You can feel free to follow the instructions here or use the QR code. We'll also be posting the PDF packet into the chat that has the links to obtain all of the CEUs. So you'll have plenty of opportunity to access those links. They'll also be, the PDF packet will be emailed to you after the webinar today. Please know that the links do expire within 48 hours. So please make sure you complete this process by Friday, October 6th at 12 p.m. Please make sure you're muted if you are not presenting or sharing. If you have any questions, you can post them in the chat. We will be holding them until the end of the presentation. We have a lot of attendees today, and we just want to make sure we can get to as many as possible. So we will hold them till the Q&A portion. Finally, if you haven't done so, please sign into the chat with your name, email address, and organization. This is how we verify attendance, and this is how we ensure you receive the presentation slides and any other resources shared today and the continuing education packet. I'm going to do a quick overview of the Michigan Opioid Collaborative. So we are an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. The MOC is grant funded through Blue Cross Blue Shield and the Michigan Department of Health and Human Services. We offer free same-day patient consultation services to help providers provide evidence-based quality addiction treatment. Our team of physician specialists are available to help with patient case questions related to treatment and management of substance use disorders, Monday through Friday, 9 to 5 p.m. Eastern Standard Time. The MOC offers quarterly introduction to buprenorphine trainings, as well as webinars on a variety of addiction, stigma, and substance use topics. All MOC webinars and trainings that offer CMEs do meet the new DEA 8-hour substance use disorder education requirement. We have a hepatologist on our team who offers hepatitis C treatment consultation within 48 hours, facilitates a biweekly case consultation webinar to review cases with providers, and has developed a 3-part webinar series on hepatitis C treatment. We have created toolkits for providers to have more resources when treating patients with multiple substance use disorders. All of our resources and events are available through our website, which we'll post in the chat here shortly. I'm going to stop sharing my screen and go ahead and introduce our presenters. Jonathan Morrow received his MD and a PhD in neuroscience from the University of Michigan, where he is now an associate professor of psychiatry. His laboratory research focuses on the neurobiology of motivated behavior, and since 2011, he has provided medication management and other clinical care to patients through the University of Michigan Addiction Treatment Services, or UMATS. Dr. Cates is a family medicine and addiction medicine physician. As a lifelong Michigander, he has a special interest in integrating addiction medicine services into primary care, with special attention to co-occurring mental health issues as well as chronic pain. Dr. Cates graduated medical school from A.T. Still University College of Osteopathic Medicine and completed his residency at UP Health System Marquette Family Medicine. He currently practices in a federally qualified health center in the Upper Peninsula and enjoys everything the UP has to offer. So with that, I will turn it over to the presenters, and you both should be able to share your screens.
Okay, great. Thank you. And thanks everyone for your interest in attending this. I'm going to share my presentation with you. There we go. Okay, so you should be able to see it now. So we'll be talking about Kratom today. I'll show the agenda. We're going to try to go through this relatively quickly because I'm anticipating that there's a lot of questions. There's a lot of interest in this, so we'll try to leave some time for that, for addressing those questions, whatever doesn't get answered in the presentation here. So the things that we'll go over, we'll talk some about where Kratom is coming from, who's using it, what the effects of it are, how to manage some of the acute problems, overdose. I know there are questions about psychosis and aggression. We'll address that, and then some strategies for longer term engagement with people who are using Kratom. So I've used both pronunciations, Kratom, Kratom. So the drug comes from Southeast Asia. The actual pronunciation of it is closer to Kratom or Kratom, depending on where you are. In the United States, people tend to say Kratom. I think just because we're Americans and we say we'll have things however we want, but the actual pronunciation is more like Kratom. I may use both pronunciations, but just so you know. So this comes from a tropical tree native to Southeast Asia. It's been used for millennia there as a traditional folk medicine. It only recently came to the United States, but there it's been used to treat lots of different conditions: musculoskeletal pain, anxiety, depression. More recently, it's been used as kind of a mild stimulant sometimes to enhance working, and like you would use coffee or something like that. And then it's been marketed also recently as a cheaper alternative to opioid replacement therapy. So someone who's addicted to opioids and then want to treat their addiction with Kratom without a prescription, without medical supervision. There's really not much formal evidence for that, but this is how it's been marketed. So the prevalence it's kind of hard to estimate exactly how many people are using Kratom. The best estimates range from 1.3% to 6%. This is from survey data. You actually see estimates quite a bit lower than that, but a lot of these estimates are going to underestimate the number of regular Kratom users. So it's really hard to say, but it's probably somewhere between 1% and 6% of the population is using Kratom. It's relatively new to the scientific community here in the West. Most of the data we have are actually from surveys and self-reports. There's not a lot of really good controlled studies that have been done on Kratom use and its effects. But we'll do our best with what is known. Most of the users in Asia have been male. In the US, there's not really that gender disparity. About half are female. And the stereotypical Kratom user in the United States is going to be a middle-aged, middle-income, white, college-educated person with private insurance. Obviously, other people can use it too, but that's stereotypically who's using this drug. There's a lot of culture involved in drug use, so that tends to be who's using it here in the U.S. The way Kratom is used is you can take the raw plant matter. This is how it's traditionally used. Take the raw plant matter, crush it up into a powder, and mix it into a tea that's then consumed like that. You can also put that powder in a capsule and just swallow it, or just brew the leaves into a tea. Now we have powders where they're doing a little bit more refinement to enhance enrich the active components in it. They have liquid extracts from the plant, and it's obtained a lot of times just over the internet or from shops that are offering a legal high. You can get it from gas stations now. In a lot of places, so it's readily available. And part of the reason for that is because it is legal. It's not regulated very much, really almost at all. So in Southeast Asia, several countries have banned the use and possession of kratom. This is a relatively recent thing, but traditionally kratom use was not problematic, but the use of it as the cultures and traditions around the use of it that actually controlled people's use of this drug have been lost in those countries, and so they're seeing a lot of problems, basically addiction problems with kratom use there. So that's why it's been banned in those countries. In the U.S., the DEA has listed it as a drug of concern, but it has not been made illegal. Here you have to, every drug has to be specifically, just the actual molecule has to be legislated on for it to be illegal. So kratom is legal in the US except for some states where specific legislation has been passed to make that drug illegal in that state. And there's a list of those on the slide here. You'll notice Michigan is not on that list. So kratom is legal here. There has been a push to ban kratom in the in Michigan. There was pushback mainly from the public, who most of the pushback was that this was people wanting to use this as a treatment for opioid use disorder, even though, as I said, there's really no evidence for its efficacy in that regard. But this was what people were concerned about. That that push to ban kratom was put on hold because of those concerns, and I don't really know if it's been resumed. I don't know that it's making any progress at this point. So at least right now, kratom is legal, and that's part of the appeal is that this is a drug that you can get legally. That makes things more popular than they otherwise might be. It also makes people think that it's very, very safe, which we'll talk about that. But so what does kratom do pharmacologically? We're learning more about this as people become more familiar with it. But the kratom plant contains about 40 different alkaloids. The most common of the most prominent of that is metragenine. That's the active ingredient in this drug. And there's also 7-hydroxymetragenine. So 7-hydroxymetragenine is actually more potent than metragenine. And in a lot of the products that are available in the US, the 7-hydroxymetragenine has been enriched. So it's more potent than anything you're going to get in East Asia, and certainly the traditional forms. What we're seeing here is more potent than that. That's typically what happens in the US. We will extract the active ingredient, purify it, inject it, and it becomes a totally different drug. But that's what we're starting to see with this metragenine. So it acts on the mu opioid receptor. That's the same receptor that heroin and oxycodone and buprenorphine, methadone. It's an opioid. It's acting on that mu opioid receptor. It is a partial agonist, though, at that mu receptor, which means that there is a limit to how much activation you can get with kratom of the opioid receptor. So no matter how much kratom you take, there's a cap on how active those opioid receptors are going to be. That makes it much safer than a full agonist, like oxycodone or heroin or something like that. It's very difficult to overdose on a partial agonist. It's basically impossible to overdose on a partial agonist without the addition of some other substance. We see that that's what makes buprenorphine so safe. So pharmacologically, you would expect kratom to be quite a bit safer than full agonist opioids, but it does act on that opioid receptor. It's also a weak antagonist at other opioid receptors, the kappa and delta receptors. It has affinity for other neurotransmitter systems, serotonin, adrenergic receptors, GABAergic pathways. And metrageny also seems to have some pain relieving effects outside of its opioid activity. So through the adrenergic effects, and it's a COX-2 inhibitor. It inhibits actually the expression of that protein. So going to be useful for pain relief in multiple different ways. The pharmacokinetics are that, so you'll get an onset of action within 5 or 10 minutes. Peak concentration is reached in about 2 hours, has a half-life that's pretty long, actually, about 23 hours. So it takes a while to wear off. But the psychoactive effects that people will notice are going to last 5 to 7 hours. At low dose, this is the interesting thing about it. At low doses, kratom acts like a mild stimulant, kind of like caffeine or something like that, mild stimulant properties at low doses. But at higher doses, 5 to 15 grams, it acts like an opioid, which is in a lot of ways kind of the opposite of a stimulant. And then at very high doses, you'll get sedation like you would with other opioids. So it depends the dose that you're taking, what effects this drug has. In the United States, people are using high doses. So here, almost all the kratom use you see is going to have an opioid-like effect on people. And we treat this basically like an opioid when we see it clinically in various methods. You treat that like it's an opioid. Okay, so there's a Kratom Association 2014 that's kind of promoting kratom use. It's sold as an energy booster, mood enhancer, pain reliever. This is what people are looking for when they're taking this drug. Like I said, at low doses, you'll get more energetic. At higher doses, you'll get some pain relief and euphoria. Very high doses, people get sleepy. They get quiet on it, like you would see with other opioids. There are other side effects that you can see from kratom use. Commonly reported is stomach upset, vomiting, tachycardia, agitation, drowsiness, hypertension, these types of things. This is with usually with higher doses of kratom. There have been reports of seizures, altered mental status, and so you can see these types of effects. This is it's basically like a delirium that people are seeing with high doses of kratom use. Important to understand that this is not detected in conventional drug screens. You need liquid chromatography, mass spec, in order to actually detect kratom. So most of the time, you're not going to know. If you're seeing somebody who's acutely intoxicated, you do a urine drug test on them, you're not going to know if they have kratom in their system unless you send it for these pretty expensive tests that aren't available everywhere. And even if you send them for those tests, those results aren't going to come back right away. It takes at least a day to get those results back. So acutely, you're not going to know if the person is on kratom.
Yeah.
So a lot of the reports of kratom use is actually self-report. And so there is evidence that kratom has addictive potential, certainly from animal studies. There's a lot of reports of kratom addiction. I have seen this clinically myself. Systematic studies of the addictive potential have not been done. But based on its pharmacology, based on the clinical experience that's out there, we have every reason to believe that this is an addictive drug. And like I say, I've seen this as people who are clearly addicted to kratom as their drug of choice. There's no reason to believe that it's not addictive. Let's see. So agitation. Actually, let me back up a sec. So one of the things that I pointed out here is agitation, altered mental status. You certainly can get that with kratom. Like I said, that's probably a delirious state. In a high dose of kratom, though, what you would expect is somebody who is kind of sleepy and out of it. It's an opioid. That's what that looks like. So I've heard concerns about people seeing people who are like acutely psychotic, basically, total break from reality and aggressive, actually assaulting people, things like that. I think it's helpful because you don't know for sure what is causing that. You don't have evidence of the kratom use acutely. You have to look at the differential of what could be causing a situation like that. Kratom use often comes along with other substance use. And when you get an acute psychosis like that, one possibility, yes, is that it's caused by substances, but most likely it's going to be something from this list. It's going to be alcohol, cocaine, amphetamines, these full-on stimulants. Cannabis can cause that. Usually makes people mellow, but you can get a really just complete psychotic break sometimes with cannabis use. Ketamine, ecstasy, similarly, these are any kind of stimulant, you can get that. Bath salts would fall into that. You can also see that in substance withdrawal, particularly with alcohol withdrawal. People get delirious. You can see that those sort of effects there. And then there's other psychiatric or non-psychiatric medications. Steroids is an example where people can have this psychosis that may or may not be aggressive, but sometimes it is. You see that really acute aggression like that. People on kratom they can be irritable, agitated, but it's not that just kind of frothing at the mouth type aggression. So I would consider these other substances if you see something like that. Another thing, you also have to, if there's a broad differential for that kind of presentation. So I would also think about, like I said, delirium, sometimes from the kratom, but that can be caused by lots of other substances as well. General medical condition, it could be a head injury or something like that. But this is any kind of disturbance of consciousness, change in cognition, perceptual disturbance that's not accounted for by a dementia. Usually lasts a short period of time, tends to wax and wane a little bit. So that means that the brain is sick for some reason, and it requires a medical workup. And then it's also, you should also keep in mind there's primary psychotic disorders, primary psychiatric disorders that can result in this type of behavior. Mainly schizophrenia, bipolar disorder, when you're seeing this complete break from reality. You'll also see that with neurocognitive disorders sometimes, personality disorders. You can get agitated depressions and anxiety. So I would keep that in the differential as well. And a lot of times these things get mixed together, multiple different causes of psychosis like that. So I would consider all of these things in a case of, even if you know that this person is saying that they've been using kratom, other people know that they've been using, all of these other things can be at play as well. It's just you're less likely to see that type of presentation with kratom alone than you are with other causes of psychosis. So what can you do for someone who's acutely overdosed on kratom? Naloxone has been shown to work in animal studies that will reverse the effects of of kratom, these opioid-like effects of kratom. And so there has been at least one case report of resuscitating someone with what looks like an opioid overdose attributed to kratom use. You can reverse that with naloxone, and there's every expectation that you would. It's the same receptor. So if you knock that off with a high affinity antagonist like naloxone, that should be a rescue medication. As I mentioned, you're less likely to see deaths from kratom alone because it's a partial agonist, and that's borne out by the data. In 2018, there was a study, they had 44 deaths identified related to kratom. Almost all of those, the kratom was mixed with other substances that could have been responsible for or contributed to those deaths. And of the cases that were attributed to just kratom, they retested blood samples, and 3 of the 4 cases contained multiple drugs. The 4th case had insufficient sample. So most of these deaths, possibly all of these deaths, are caused by multiple substance use, not just kratom. That's what you would expect based on the pharmacology. You would expect something that looks a lot more like buprenorphine than a full opioid agonist like heroin or oxycodone or something like that. All right, but I think I should turn it over to Dr. Cates for the rest of this.
Yeah, thanks, Dr. Morrow. There's definitely been some good, I've been really interested by kind of the discussion that's going on in the chat here. And so I've got, kind of some slides, just kind of general kind of addiction medicine slides, but I'm curious. So one of the things that it was really honestly kind of fascinating about this topic is the tremendous interest in this topic. This is, kratom has been around for a while. It was something that we were seeing in residency. It's not necessarily a new thing. It's something that we're having, you can get it in, some health food stores, gas stations, tobacco shops. It's something that's been around for a while. I'm curious, is there anybody who would just can pop on really quickly and say, is there something that's changed? Is there something that's new? Is there something that you're seeing in the community that is kind of leading to this tremendous interest in this topic? I mean, we do these roundtables and discussions on various addiction medicine topics, and we'll usually get 20-30 people interested. We have 241 participants in the chat right now, so I'm curious, is there anybody who can maybe speak up and say, is there a specific reason why this is kind of piquing a lot of people's interest, if that makes any sense?
My name's Karina Haller. I'm the director of an inpatient psychiatric unit. About 5 or 6 years ago, maybe, we started seeing particularly college-age kids that were coming in and reporting that the only thing they had used prior to coming in was kratom, and they would have florid psychosis, agitation, aggression. They were just very, very difficult to manage. And it seemed like as soon as it cleared their system, they went back to school, they did fine. And to the best of my knowledge, they've never been hospitalized again since. So we've seen that probably within the last 5 years, a definite increase in particularly that age group reporting they tried it one time, that's what happened, and then didn't need treatment again afterwards. Our emergency department is also reporting people coming in with agitation and psychosis, and then pretty rapidly it's clearing and then just discharging them, and they're reporting that's what they used.
So are these, as Dr. Morrow was mentioning, are these mainly self-reported, or are these confirmed with send out tests? There was some discussion in the chat about, there are some strips that some people noted having, specific strips to test for the kratom. are they are these confirmed, or is it basically just on these self-reports?
It is self-reported. There are family and friends that have confirmed a number of them, though, from their perspective. They felt like that's what was causing it as well. No test strips or anything like that, though.
Sure. And does that seem to, I mean, people can just give thumbs up in the chat if they want. Like, does that seem to match, kind of what other people are seeing? And is that kind of what's leading to a lot of this? Yeah, I see there's. Okay, good. Yeah. So that's kind of one of the reasons why this is an interesting, kind of an interesting, topic to have. This was brought to us as something that people wanted us to talk about. What's interesting is, as I'm sure a lot of people were noting with what Dr. Morrow was talking, this psychosis is kind of not what we would expect with Kratom. At the low dose, it does have, a mild stimulant effect, but not enough that we would expect to be not enough to be, what we would expect to be causing, enough delirium and psychosis that they would need to be admitted to the psychiatric ward. So it's kind of an interesting thing. So that's kind of one of the curious things that we're trying to figure out is what percentage of these issues that we're seeing are atypical responses to Kratom that we're seeing in the community, or what percentage of it is issues with the supply that people, because it's a dietary supplement, it's not regulated, are these people taking Kratom and they're taking something else that they don't think they're taking, or they don't know that they're taking, whether it's meth or things like that. But again, we would expect that, that would be showing up in a lot more urine dips. So it's kind of an interesting conundrum that we kind of have stumbled into here, that we're seeing a lot more of it. Maybe, the way that it's manifesting is kind of not what we would expect. So I think that there's opportunity here for us to, kind of do further, investigation when we have these cases, to try to do more send out labs, try to get more confirmation about exactly what is causing these. I frequently say that that frequently our patients don't read the textbooks, right? And so it's very, it's kind of interesting for us to hear, oh, this psychosis caused by Kratom, that doesn't seem to cause a lot of the issues. A lot of people are bringing up the withdrawal. It is possible that, with withdrawal from Kratom or other opiates, that there is some, agitation from withdrawal, but it shouldn't necessarily be a psychosis, right? Think about, kind of the standard, the person quits smoking and they're just a little bit more irritable and they, they snap at their kids more. It should be, more that, just, anxiety, difficulty tolerating, uncomfortable situations, stuff like that. I wouldn't really anticipate that it would be the psychosis, but I mean, I think that this is something that I think there's a lot of kind of good, more that we need to learn about this. So I think that there's these questions, you kind of bring up a lot of more questions kind of in our minds about what exactly is going on. So what I can do here is I'm going to just really quickly go through a couple of these my slides on kind of general addiction medicine, how we react to issues with when people are when they're dependent on a substance. And then we'll kind of go ahead and kind of tackle these very specific questions. Let me go ahead and pull these up here. So let me share my screen. Share my PowerPoint slide. Oh, okay. Well, I have a new computer, so it's not letting me share my slides. Okay, that's great.
Is it giving you a message?
Yeah, because it's a new computer, I need to go and then restart Zoom and all that stuff. So, how about we,
You want me to pull it? I can pull it up.
Yeah,
And
yeah,
share
go
it
ahead.
If you want. Okay.
But
Give me
sorry
1
about
second. I'll
Yep.
get that done though.
Yep.
Sorry, I closed it out, but it'll come up in a
Yep.
second.
I have the slides too. I just didn't know if you had different slides, Dr. Cates.
Yeah. So while you're pulling that up, what I can do is I can just kind of start talking. So kind of the overarching goal that we have with all these discussions is harm reduction. How can we reduce harm? How can we make sure that people are alive? You can't help people who are dead, right? So it's a set of practical strategies, basically to kind of limit the negative consequences of these drug uses. And then harm reduction is critical to keeping people who use drugs alive and as healthy as possible. So again, you can't help somebody who's dead. So what we're doing is we're doing a lot of work. You can go ahead and go on the next slide. We're doing a lot of work to again, to reduce the dangers related to substance use, and kind of as we talked about, the risks of overdose from the kratom itself is relatively low, but again, we have to be aware of when it's being mixed with other medications. Specifically, we think of benzodiazepines as being significant. And so this is where having those discussions with our patients, non-judgmentally asking them what they're doing. It sounds like people are doing a great job doing that because patients and their family are telling them what's going on. But it's really important that we kind of get a good idea of what's going on with the whole person. You go ahead and go to the next slide. So what's interesting is the for patients who are on kratom and who are trying to get off, it's important that we're having a very very practical discussion with them. When people are withdrawing from kratom, if they're having those cravings, they might actually be tempted to use other street drugs, whether it is heroin or pressed pills that both have fentanyl in them. A lot of people might be tempted to use other things if they're withdrawing. So this slide on the left-hand side, we actually do use buprenorphine for the treatment of kratom use. So if you have somebody who is using kratom, who is trying to stop using, recommend that they discuss with a physician about being put on buprenorphine. Some physicians might not be comfortable with that. That's why there are those of us who are board certified in addiction medicine who can help them out. If anybody wants information on what doctors in the UP are prescribing buprenorphine or what treatment options there are available, feel free to reach out to us. And we can kind of get people in touch. And so things like needle exchange, stuff like that, are going to be really beneficial to make sure that these patients are, alive, so that we can, keep them safe in the long term. Go ahead and go to the next slide. So yeah, and so this in kind of this arena, there's some good discussion in the chat about safety of kratom versus other things. Part of the thing is we look at, I would take an alive patient, maybe using buprenorphine or kratom, than a dead patient who overdoses on heroin. But the problem is, and so there is that discussion. The problem is that kratom is unregulated. So you don't know what you're getting. You're buying it from a gas station. People don't know. So Could it be beneficial for some people to get off opiates, to get off opiates, to stop using heroin, alcohol? It could. The problem is it a safe way? There are safer ways. And so working with an addiction medicine doctor would probably be safer. Again, because it's unregulated, you just don't know what you're getting from a gas station or from a health food store. And so that could be contributing to this psychosis, this withdrawal. If you stop taking it, you don't really have anybody who can help to manage those symptoms, to make sure that you don't end up, that the individual doesn't end up having to go into a psych ward, to manage the withdrawal. So that's why working with an addiction medicine doctor is going to be really beneficial. Go ahead and go on to the next slide. So again, that when you have a patient who's struggling with this, approaching them, non-judgmentally, and offering them the option. I have lots of patients of mine in my addiction medicine clinic who do use Kratom. They come back on confirmatory drug tests, and I have discussions about them that, I would rather them use Kratom than use heroin, but there are other things I would rather have them use than Kratom. So, so getting them to be using, what is the safest non-judgmental thing that we can do, kind of what is the best thing we can do. So, and this is just kind of, the next slide is just kind of very, very general, addiction medicine. We want to talk about people and kind of, that we don't see somebody as an alcoholic, a druggie, a Kratom user. We're all people. And, like Gabor Mate says, we don't say, why are you addicted? We say, why do you have pain? What's the pain that you're trying to get over? So we're really trying to, to really focus on looking at, this is a person with a problem, not a person who's defined by their problem. So I think that this is kind of maybe a good spot. We got, just under 20 minutes. I would kind of love to discuss in a couple slides. There's some good, we've got some good resources for other slides here. What are so maybe I can address one of the slides that, one of the questions I saw go by in the chat. Yes, naloxone has been shown to be beneficial in some instances of Kratom overdose. Naloxone is one of those things where if an individual is not overdosing, giving them naloxone isn't going to hurt them. But if somebody is overdosing, giving them naloxone can be life-saving. So, so it can be beneficial for Kratom intoxication. Yeah. So what other questions do we have? And Dr. Morrow, feel free to, pop in if there's anything that you wanted to say, any comments on my little spiel there.
We have quite a few questions, so if you don't mind, I'm just going to start reading them one by one. Okay, so has there been any studies about contraindications between Kratom and certain prescription meds?
I don't know. I don't know are you familiar with that, Dr. Case?
I don't know any specific studies, but I would say that, kind of the general response that I would have is, we mentioned earlier kind of the pharmacology. It is interacted by the CYP enzymes. And so I would have to look exactly which enzymes and which are correlated. So, that has to do a lot to do with it. But in general, any medication that is going to be sedating, I would be very cautious on, specifically benzodiazepines, alcohol. Those are the things, as we said, most people, it's very unlikely that you can overdose on a partial opioid agonist, but it's not impossible. And most of the overdoses are because of a combination with a sedative a sedative, anxiolytic, or alcohol. So that would be the, kind of my answer to that question.
Are you, you're muted?
Thank you. Does Kratom react to Narcan? You answered that. I'm with Marquette CPS, one of the folks that bothers your office, Dr. Cates, and I'm in this webinar due to recently hearing more regarding use of the drug from clients and friends and hearing use stories when traditionally I've not heard anything about Kratom. I don't know if you wanted to comment on that.
I'm just going to say that there's a big, kind of pop sci, love fest with Kratom. There's a couple, podcasts on, that people mentioned in here. There's actually a documentary on Netflix that I've seen. Honestly, I'm very hesitant, when in any, if you're getting information from, a podcast, a random Netflix documentary, I'm very cautious, to recommend things, to people. And so I just think that it's become more popular because, oh, it's legal and it's a plant. Well, opium also comes from a plant. Arsenic is naturally occurring. Just because something is natural, nightshade, is toxic, right? Just because something is a plant doesn't necessarily mean it's good. It's good for you. And I think there's this idea that because something is legal, it's okay. This is one of those things where it's mainly kind of just a loophole, kind of like, the K2 bath salt, stuff like that was a loophole. I would say that there's a lot of misinformation that people kind of think, oh, it's legal, it's a plant, therefore it's okay. And so it's very popular. And then especially with the amount of prescription opiates being cut down, I think people are turning to it when in the past, they were maybe taking prescription opiates. And so I totally understand, that people are looking for relief and people are looking for things that will make them better. But there are safer alternatives out there that I would recommend above, buying, buying stuff from, unregulated, medications from, gas stations and stuff like that. So, that's my discussion. And, there's just, people are asking questions in the chat about, what if somebody finds a safe, reputable dealer? Unfortunately, I just can't, I don't know if there would be anybody that I would consider a safe, reputable dealer of Kratom. And I just don't really know how to answer that because, the context that I have experienced with, there are better things to use. We have great medications, that I use every day. That I would recommend over Kratom. I'm just, if I'm sure, if Dr. Morrow would agree with that or not, but I think there's better options.
Yeah, I agree. I mean, it's just, I mean, fundamentally, it's not a regulated product. And so there's a reason we have an FDA, so if anything that's just not regulated at all like that, even if the person's trying to be safe and responsible, which a lot of them honestly are not, but even if they're trying to be, without any kind of regulation or anything like that, you don't know how much is in there, or what else is admixed with. And we have products that do the same thing safely. So.
And there's and part of the problem is that there just aren't a lot of providers who want to do the treatments that are beneficial. And so I would, if anybody wants to learn about, how to appropriately treat people with substance use disorder, welcome to the Michigan Opioid Collaborative. Have we got webinars for you? This is a great place to start. But there are better options out there. I mean, it's amazing. I mean, if you even look at, if you go to, even like a GNC and buy, supplements off the shelf there's a lot of them that have all kinds of weird stuff that are being mixed in that if you actually do tests. So even in, kind of a reputable place, you just have to be careful with what supplements you buy, stuff like that. So it's a complicated discussion. And I think there are better things to treat a lot of the issues that people are taking Kratom for.
Thank you. I'm going to address another question. Is there any reason to believe that there may be some other chemical in Kratom as this product is not regulated or approved? I think we've spoke to that. Also, do we know if Kratom constricts pupils as opioids do?
Oh, constricts pupils? I would think so. I mean, I don't know why it wouldn't. Yeah, it should. I mean, it's acting on the same receptor. I guess I can't say specifically that I've seen that, but yeah, I would think that it would.
Okay.
It
Thank
should.
you.
Yeah.
Does the UP have an overdose fatality review committee? Do other OFRs include Kratom in case studies?
I don't know if we have an overdose fatality committee. I would love to be a part of one if one exists. I'm not aware of it. I work with the only organization that has in the UP that has 2 addiction medicine doctors under one roof. So, there's just not a lot of resources up here. So yeah, if anybody wants to make this happen, I would love to be a part of that. I think it would be really, really beneficial. We're doing a lot of work with the Michigan Opioid Collaborative to working with the state on like state dashboards to be tracking overdoses and stuff like that. So yeah, if there's a committee, I'd love to know about it.
Hi, I can chime in there. My name is Morgan Kramer. I coordinate the Michigan Overdose Fatality Review Program. We currently don't have any teams up in the UP, but that is one of our big goals for this year. So I'm going to go ahead and throw my contact information as well as an interest survey in the chat. If you're interested in being a part of this, whether it be in the UP or otherwise, just go ahead and take that survey and we'll be reaching out to you.
Wonderful. Thank you.
Thank you. Kristen Olson, are you able to unmute? I'm looking at your question. I'm not sure I understand it. I have seen a flag flying offering this at a dispensary. Can you comment on this?
I think it's kind of been spoken to, like as far as the regulated and is it safer there? There was a comment about, get where you get it and that sort of thing, but I don't know. I just was curious if it's kind of, I don't want to say better than, but I've just noticed that that's something that's popping up.
Mm-hmm.
What's interesting, if you go to like Minnesota, you'll see places where there'll be a sign on the front of the building where it'll just say Kratom. What's actually interesting is a lot of them, if you actually purchase it, if you read the package, it will actually say not for human consumption. It will say, biological sample only. It's interesting if you look at it, there's a lot of, it's an interesting to actually examine the packages. But yeah, a lot of, tobacco stores and stuff like that, you'll see flags and stuff like that.
Dr. Cates or Doug? Oh, go ahead.
Well, that's a way of insulating themselves from prosecution is saying that it's not for human consumption. Bath salts. That's why bath salts were called bath salts, because they weren't sold as to be consumed, even though that's what people are actually doing with them.
Dr. Cates or Dr. Morrow, are you seeing a lot of Kratom use in teens? What is the legal age to purchase it?
I mean, I don't know that there is a legal age to purchase it. Like I say, I don't think it's regulated at all. But I mean, mostly this is older folks. I've seen it a little bit in teens, but it's usually older folks who are using it, in my experience anyway.
I haven't seen it a lot in teens, but it doesn't mean that they're not using it. I just haven't encountered it.
I don't think it's cool enough for the teens. So.
Okay. Wondering if you know of any data on NAS, neonatal abstinence syndrome, associated with Kratom.
Good question. I haven't seen that, but I don't see a lot of the pregnant. I don't know if Dr. Cates does. I don't deal with a lot of OB stuff. I mean, you should get that You should get that similar to other opioids. I don't know why you wouldn't. And you'd probably treat it exactly the same, but yeah.
Yeah, I have a lot of pregnant patients. I haven't encountered them using Kratom, but the problem is usually I'm seeing patients, because I'm managing their opiate use, their chronic pain, stuff like that. They don't need to be using Kratom, right? So my patients don't have issues with it. But from a physiologic standpoint, there's every reason if I had a patient of mine who was pregnant, I would tell them that they are putting their child at risk for NAS. It just, from a physiologic standpoint, I don't know how it couldn't. But that's kind of an issue we have up here is we have really, really high rates of NAS. But the rate of opiate prescribing doesn't match the rates of NAS. So it's kind of a long ongoing project as we're trying to figure out kind of what our elevated rates of NAS up here are attributed to. And it's possible that it could be some Kratom use.
Thank you. With the fentanyl spike and other narcotics, should we be concerned about spiking Kratom?
Yes.
Yes.
Yeah. They'll spike anything with fentanyl, and this is a great product to do that with. So yeah, I would expect to see that. Yeah.
Okay. There is something someone shared with me directly that I will share with everyone, the doctors. As a mom of teens, Kratom is being used by a few that my sons have told me about in Marquette County and Delta County.
Mm-hmm.
Unsurprising, but sad.
Okay. Any questions I missed? Feel free to unmute. There's a lot of.
Hi, Dr. Myrick here. Just a comment, people were asking about the laws around Kratom. It looks like I just did a quick search. Florida has it set at age 21 to purchase Kratom. And there's a bill in the legislature currently introduced earlier this year in 2023. And then over the summer was paused for, the summer, but they're looking at it as of today. So I don't have the details if it's going to be 21 like Florida. I haven't gotten that far in my research, but wanted to comment on that. And they did look up some interactions with a few drugs. Specifically mentioned was Effexor with Kratom would decrease metabolism of the Effexor, so you'd have higher levels and potential side effects. And there was one other one, of course, naltrexone, opioids, those sorts of normal things, but there was Seroquel was the other listed one that could again decrease metabolism, so you'd have more side effects.
Yeah, it is metabolized by, I forget which one, but one of the CYP.
It is cytochrome P450.
Yeah.
P450s.
Well, thank you, everybody. We have 1 minute left, and we just want to thank you for attending the webinar today, for engaging. I know there were a lot of questions and comments. If you have any other questions and you would like us to address, please feel free to reach out to your local behavioral health consultant. And we'll be happy to address those as possible. Thank you so much for joining us today. We hope everybody has a good rest of the afternoon.